Hello, my name is Dr. Kenneth Fong from Oasis Eye Specialists in Malaysia. Thank you for joining us today at the Quantel Medical Laser Symposium at APAO Virtual 2021. Thank you for giving up an hour of your time to join us on this very interesting symposium on laser therapy, the latest in laser therapy for glaucoma and retinal diseases. There is a plethora of work done in this area in the last few years, and I've very pleased to be joined by three distinguished speakers from around the world to share their experience with us today. So the title of today's symposium is Laser Treatment Trends in 2021 from Glaucoma to Retina. And I'll be moderating this session. The first half of this symposium will be focused on glaucoma, and we are very fortunate to be joined today by Dr. Jimmy Lai from Hong Kong, who will be sharing us his experience with SLT laser treatment. From Poland, Dr. Jaromir Wasyluk will be talking about SubCyclo laser, the concept, and whether it's a safe alternative to glaucoma surgery. The second half will be focused on retinal diseases, and Dr. Victor Chong from the UK, who's one of the pioneers in SubLiminal laser therapy, will talk about whether macular laser photocoagulation is still relevant in 2021. And finally, I will cover the use of 577 nanometer SubLiminal laser therapy for diabetic macular edema and central serous choroidal retinopathy. So our first speaker today is a very experienced glaucoma specialist and from Hong Kong, Dr. Jimmy Lai, and it gives me great pleasure to introduce him. He'll be talking to us about his experience of SLT laser for glaucoma.
Welcome to the Yi Symposium on Selective Laser Trabeculoplasty. It's my honor to share with you new data on SLT. I have no financial disclosure. Glaucoma is a multifactorial disease characterized by progressive damage to the optic nerve that can lead to blindness. And the standard treatment for primary open-angle glaucoma and ocular hypertension is intraocular pressure reduction. Medical treatment has been used for decades in the management of glaucoma. However, there are many disadvantages of using medical treatment. First, patients need multiple clinic visits for monitoring and treatment adjustment. Second, there are multiple ocular and systemic side effects associated with long-term topical medications. Here, I have listed some of them. And long-term topical medications is one of the risk factors for glaucoma surgery failure. And last, we have to consider patients' drug compliance for the medical treatment to be effective. This is a picture showing the eye of a patient on long-term glaucoma medications. You can see the diffuse corneal erosions as a result of drug allergy, drug toxicity, and dry eye. Selective laser trabeculoplasty came into clinical practice in the 80s. The laser modulates trabecular meshwork to increase aqueous humor outflow from the anterior chamber. SLT reduces intraocular pressure with a single painless outpatient laser procedure. Its mechanism by which SLT lowers intraocular pressure is likely to be multifactorial. It has a minimal recovery time. It has a similar IOP reduction magnitude to prostaglandin analog monotherapy or combination therapy. SLT also has a good safety profile. It is easy to use and it can be repeated. The selective nature of SLT relies on its property of having a very short pulse duration in terms of microsecond. When a laser beam has a very short pulse duration, its heat energy will be contained inside the target tissue and will not be dissipated to the surrounding tissue. In addition to IOP reduction, SLT has been shown to decrease the diurnal IOP fluctuation. SLT is also effective for early and advanced glaucoma, but it may not be effective in certain forms of glaucoma like a uveitic glaucoma or neovascular glaucoma. And its IOP lowering effect seems to decrease with time. However, even if it is so, SLT can be repeated to achieve additional or recurrent IOP reduction, even in eyes that only had a modest response to the initial treatment. Although SLT achieved good IOP reduction in majority of patients, it's not effective in up to about 35% of eyes. And it's very depressing to treat the patient with SLT and find that there's no response. So, can we have some predictive factors of SLT response? Here are some of the relevant facts that you can consider. First, a positive prostaglandin analog response may predict both SLT outcome and the magnitude of IOP reduction. Second, IOP reduction of SLT is not influenced by pre-laser use of prostaglandin analog. Third, the higher baseline IOP is related to a greater reduction only if there is a response. So to me, this is not really a predictor, because even if you have a high baseline IOP, it doesn't mean that you always have a response to SLT. The last one is the most accurate predictor of SLT response is the response of the first treated eye. That means the success in the fellow eye is a very strong predictive factor for the response of the second eye. But this has a very limited clinical application to me, because I treat both eyes at the same session, so I cannot wait for the response of the first eye to decide the response of this fellow eye. This is my personal SLT technique. I stop all anti-glaucoma medications at least 3 days before treatment, and on the day of treatment, I give bromonidine and anesthetic drop to the eyes to be treated. I laser all visible angle with an initial energy from 0.6 to 0.8 millijoules. I look for microbubble formation to titrate the energy level. There are different types of laser for trabeculoplasty: ALT, SLT, micropulse laser, pattern laser. Aside from the argon laser, ALT, none of them is superior to the others, so it's just a matter of surgeon's preference and availability of the laser machines. Before I perform SLT, I always ask patients to stop all the anti-glaucoma medications at least 3 days before treatment. First, because I want to know the baseline intraocular pressure without the influence of glaucoma medications. Second, if you have a higher pretreatment intraocular pressure, you will see a more obvious and a greater intraocular pressure reduction. These two charts illustrate what I just said. After SLT, there's always an IOP spike. Though transient, it can be alarming. I routinely give oral Diamox just before I proceed to the SLT procedure. And I don't give steroid eye drops after SLT unless there is a very excessive anterior chamber reaction, or if the eyes are very injected. I'll follow up the patients on day 1, 2 weeks, and as clinical need. And I watch out for corneal haze because it sometimes occurs in patients, and these patients will complain of hazy vision. And then I titrate the glaucoma medications accordingly. I observe for at least 4 weeks before I tell the patients whether the SLT was successful or not. This diagram illustrates an ideal IOP response to SLT. If you have a high pretreatment IOP, you will see a very drastic reduction in the pressure on day 1, and then the pressure will rise gradually to a level lower than the pretreatment IOP. This diagram shows an unsuccessful SLT treatment. In some cases, even there is a drastic reduction in the intraocular pressure on day 1, the pressure will gradually go back to the pre-treatment level. In some cases, it's not even a slight reduction in the intraocular pressure right from the beginning after SLT. Sometimes I see a delayed IOP response to SLT. The persistent IOP reduction only starts at around 4 to 8 weeks after SLT, when you think your SLT has failed. Here, I would like to share with you the Light study, which is SLT versus eye drops for first-line treatment of ocular hypertension and glaucoma. This is an observer-masked, multi-center randomized controlled trial. Subjects recruited were treatment-naive patients with primary open-angle glaucoma or ocular hypertension without ocular comorbidities between the year 2012 and 2014 at 6 UK hospitals. They were randomly allocated to initial SLT or to eye drops treatment. A target IOP was set according to the glaucoma severity of the recruited subjects. The primary outcome was health-related quality of life at 3 years, which was assessed by the EQ5D questionnaire. Secondary outcomes were cost and cost-effectiveness, disease-specific health-related quality of life, clinical effectiveness, and safety. The EQ5D questionnaire considers 5 dimensions, including mobility, self-care, usual activities, pain or discomfort, and anxiety or depression. There is a 5-level response in EQ5D, including no problems, slight problems, moderate problems, severe problems, and unable to do. A total of 718 patients were enrolled. 356 were randomized to the SLT group, 362 were randomized to the eye drops group. For the primary outcome, there was no statistically significant difference between the two groups. However, at 36 months, 74.2% in the SLT group required no eye drops to maintain the intraocular pressure at target. And eyes of patients in the SLT group were within target intraocular pressure at more visits than in the eye drops group. None of the patients in the SLT group required glaucoma surgery to lower the intraocular pressure, whereas there were 11 patients in the eye drops group who required glaucoma surgery to lower the intraocular pressure. Over 36 months, from an ophthalmology cost perspective, there was a 97% probability of SLT as first-line treatment being more cost-effective than eye drops first-line treatment. This trial shows that SLT is safe and effective as a first-line treatment for open-angle glaucoma and ocular hypertension. SLT provides superior IOP stability to drops at a lower cost and allows 74% patients to be drops-free for at least 3 years after starting treatment. SLT is associated with lower cost, good clinical outcomes, with lower symptom scores and drop freedom for most patients. Therefore, SLT should be offered as an alternative to IOP-lowering drops as a first-line treatment for open-angle glaucoma and ocular hypertension. There is also a like study in China. This is an unmasked, single-center, randomized controlled trial. Subjects were recruited at the Zhongshan Ophthalmic Center from March 2015 to January 2019. Subjects were randomized to either SLT as an initial treatment or eye drops as an initial treatment. The primary outcome was health-related quality of life. Secondary outcomes were clinical outcomes, cost effectiveness, glaucoma utility index, glaucoma symptom scale, visual function, and safety. Compared with participants in the Light UK trial, participants in this trial were younger, more myopic, and had more severe visual field defects. With a slightly different subjects' characteristics, we'll see if the Light study in China yield similar results as the Light study in UK. In conclusion, why do we do SLT? Because it is superior to medical treatment in terms of cost and adverse effects, though SLT is not effective in all types of glaucoma. It is safer than glaucoma surgery, though the IOP reduction magnitude may be less. It should be used as an initial treatment in selected and suitable cases. And how do we do SLT? We simply laser the trabeculum. These are the take-home messages of today's presentation. Thank you.
The next speaker is Dr. Jaromir Wasyluk from Warsaw, Poland, who's also a very experienced glaucoma specialist in Europe. And he'll be talking about his experience with the SubCyclo laser for glaucoma and whether it's a suitable alternative for glaucoma surgery.
Hello, ladies and gentlemen. Thank you for joining this scientific event. And the topic of my today's talk will be SubCyclo concept and benefits, and a question whether it may be a safe alternative to glaucoma surgery. My name is Jaromir Wasyluk. I'm an ophthalmologist based in Warsaw, in Poland. There are several new lasers brought to the market last years. As you can see, there's a growing number of it. And among these lasers, is there anything new, anything interesting, anything worth your attention? I hope there is. Laser therapy target tissue may be a silvery body. You all know ECP, which is endoscopic cyclophotocoagulation, and you all as well know thermal TCPC, which is classical method used from 70s, from many years, which is thermal transclear cyclophotocoagulation. But today we'll talk about new child of this technology, which is SubLiminal TCPC. The machine is called SubCyclo, transclear subthreshold treatment of our glaucoma patients. There are several technologies hidden in one box. As you can see, there is Retina part and there is also glaucoma part. And today we'll talk about the new technology which is called SubCyclo, transclear cytophotocoagulation performed by subliminal energy. What is the crucial difference between these two technologies, the older one and the new one? SubCyclo, the laser beam is fractionated into the small shots, and there are gaps between these shots, gaps in which tissue has enough time to cool down. That's why this is low temperature procedure, opposite to thermal-based CPC, which is classical method when there is constant delivery of energy, and that's why there is coagulation of tissue. This is high temperature procedure. This is the main difference between these two methods. What's the mechanism? How does it work? What's the mechanism of action in subliminal TCPC and SubCyclo method? This induces uveocular aqueous pathway by ciliary body remodeling, which I will show you on the next slides. It selectively impairs ciliary body pigmented epithelium, which is next mechanism of action. There is no ciliary body photocoagulation, thermocoagulation, which is very important because that is why you can repeat the procedure. There is no significant pain nor inflammatory reaction after the treatment. There is broad spectrum of indication. That's why SubCyclo is not only last resort therapy, it may be used as a second-line therapy in glaucoma. There is very nice work published last year by a group of Professor Yves Lacar from Paris about how it works, how SubCyclo works in microscopic images. Here you have images of UBM, ultrabiomicroscopy, showing you that after the procedure, after the SubCyclo was performed, there is small space, suprachoroidal space, shown here, when the fluid from eye can leave the eye. So this is the new uveoscular aqueous facility built after the procedure. And indications. So, who will benefit the most from this new method? especially patients, of course, with glaucoma, moderate to advanced stage. This procedure is reserved for second stage, second line of therapy. Patients with refractory glaucoma, these with drug resistance with high IOP. Also patients which have topical medications intolerance. So there is allergy or intolerance or toxic reactions to drops. Patients with previous surgical failures where you simply cannot do another operation. And anticipated surgical problems you can expect during operation, especially this may happen in secondary glaucomas like neovascular glaucoma, aphakic glaucoma, or post-traumatic glaucoma. And next slide, indications continued, because there is several indications, there is broad spectrum of indication in SubCyclo. Patients' hesitations and fears of incisional surgery, especially in these patients who underwent surgery before and there was failure of it and they simply don't want to be operated once again. Severe visual field defect with possibility of so-called whiteout syndrome, when there is very big defect of visual field and simply visual field can fade away completely after surgery. So very, very advanced glaucoma. Of course, you can use SubCyclo like a last resort or palliative therapy, like alternative to classical CPC, thermal CPC method, which you have in the same machine. So anytime you want, you can switch to the other method. And it can be a separate procedure or combined with phaco, which is very interesting. You can combine with other operations also. So this can be alternative to trabeculectomy or with phaco to phacotrabeculectomy. Technical, some practicals here of SubCyclo. Here you have interface of the machine. This is the touch screen, which is very user-friendly. You can see here some main things. This is laser power in watts, timer, which informs you by voice announcements during the procedure what's going on, how long you do it, aiming beam brightness, and the duty cycle. So how much energy is delivered to tissue, you can adjust it as you want, but we usually use this default settings, which is 2 watts of laser power and 31.3 duty cycle. And SubCyclo technique. Laser treatment is delivered by moving the tip slowly around the limbus in a continuous way in sliding motion. You start with superior quadrants and then you give patients some break and then you do the lower quadrants. Of course, first you have anesthetize patient by retrobulbar block. We do it like this, or peribulbar block. In some cases we also do some sedation, intravenous sedation in some complicated cases. So another slide with SubCyclo technique. Here you can see how I do this in this patient. You just slowly move the probe, sliding in around limbus. It's 3 millimeters from the cornea, where the ciliary body lies underneath sclera. You do it 2 times 80 seconds. So the procedure is very fast, only 160 seconds altogether. The energy is 2 watts and duty cycle 31.3. Post surgery, we usually give patient topical steroids for a few weeks and topical non-steroidal anti-inflammatory agents also. Side effects. There are of course some side effects. Unfortunately, there are transient and mild. There may be some pain or discomfort after the laser. There may be some hyperemia, of course, because you touch conjunctiva. That's why you should put some viscoelastic or artificial tears drops before. Sometimes there will be some blurry vision for a few hours or transient accommodation problems. We also expected hypotony for a few days in some patients in our clinic. And efficacy of this procedure. Efficacy is quite good. The first published work was by Professor Tan from Singapore. It was in 2010, and this study revealed IOP reduction of 33%, as well as 61% of medications reduction, which is very important for patients, and the success rate in 1.3 sessions was 73. But it was promising procedure, so there were very many studies done after this. Here we have some of them. Almost every year studies published in different journals, and efficacy ranges from 27 even to 54% of hypotensive effect. As you can see, it's really good. So you can do cyclophotocoagulation in two different ways. In summary, there is still thermal TCPC, the older method you can perform. This is thermal, this is photocoagulation. You use continuous beam of laser. Duty cycle is 100%. There is inflammation, and this method is burdened by many side effects, so you should do it in like a last resort generally, and you cannot repeat it. Completely different is the new method, which is SubCyclo or SubLiminal TCPC. This is non-thermal. The beam is fractionated. The energy is low. There is almost no inflammation, and you can repeat it when the hypotensive effect fades away with the years. And EGS guidelines also tells us that the first choice is monotherapy, but when it does not work, we should move to the second stage, second line therapy, and you can see laser is together with incisional surgery, like alternative in second line of therapy. Here we have, as a summary, the treatment algorithm from outpatient clinic to surgery, starting with medication, then second line minimal invasive glaucoma surgery and classical surgery, and thermal TCPC as a last resort treatment. But there are new data coming to us every day, so I think we should rethink the algorithm we use every day. That's why we should move selective laser trabeculoplasty as a first-line therapy, but also we should consider subliminal TCPC, so SubCyclo, other name, like a second-line therapy in our glaucoma patients. Take-home message. There is broad spectrum of indications of this method. No clinically significant tissue destruction. This is repeatable procedure. There are slight and transient side effects and long-term hypotensive efficacy in clinical trials. This may be done as a standalone procedure or combined with others, less aggravating alternative to trabeculectomy. Thank you very much for your attention.
Our next speaker will be Dr. Victor Chong. We'll talk about macular laser photocoagulation and whether it's still relevant in 2021. Dr. Victor Chong is a very experienced pioneer of subliminal laser therapy and has been published widely in this area for the last 15 to 20 years. He's also the founding president of the newly formed Subthreshold Ophthalmic Laser Society, which focuses on developing guidelines, research, and sharing work on subthreshold laser for various macular diseases. So over to you, Victor.
Ladies and gentlemen, thank you for the invitation for me to give this talk on macular laser, whether it's still relevant in 2021. Here are my financial disclosure. The only relevant is that I am a consultant for Quantum Medical, which is a laser manufacturer. The first question I want to raise is that when you go to US conferences in the past few years, you would have thought that our American colleagues are no longer using laser. However, that when we actually look at one of the studies was only finished a few years ago, the protocol T. As you all know, that the RCR net is quite often considered as a real-world trial, and most patients was recruited into the study. And in this particular protocol, they're comparing 3 different types of anti-VEGF for diabetic macular edema. So I'm not really want to spend a lot of time discussing the trial and the data. However, just to look at some of the information provided in this particular study. when you're looking at the ocular baseline characteristic, any prior laser are around 36 to 39%. And indeed, that if you're looking at the number of patients that was treated in this trial, that had around 9 to 10 injections. And indeed, that even with that high number of injections in the first year, there is still 37 to 56% of patients require more laser treatment within the trial. So when you start with around 40% of patients that who have laser before joining the trial, and then another 40 to 50% require treatment in the first year, despite almost 10 injections, you will realizing the fact that laser is still very commonly used in the United States for diabetic macular edema. So the basic concept is that even in a recent study, laser is still used in majority of patients. The second question would be that who should we treat with laser? I think I need to emphasize the fact that I'm not saying that anti-VEGF therapy is something that we should not use, or even claiming that laser is better than anti-VEGF. However, that we need to consider laser is very useful in conjunction with anti-VEGF, and indeed there is sometimes that we will use laser first and sometimes that you use otherwise. And that is why that we need to understand who should we treat with laser. So if you're looking at a slightly older study and the RESTORE study, that is the approval study for diabetic macular edema in Europe. And in this study, there is a true randomization to 3 groups of patients. The first group of patients are ranibizumab on its own because they were provided with sham laser, and then a group of combination of the both ranibizumab as well as active laser, and then there is a group of sham laser. So this is a true randomization of 3 different groups, because some of the other study that you thought that they would use laser as well as a combination, but in some of those studies, laser was deferred rather than started from the very beginning. So look at this group, and again, I'm not going to spend a lot of time on the overall result of this particular study, but to focusing on the differences when you're looking at different group of patients. So when you're looking at the far right hand side, that you would see that when you are in a very thick retina with more than 400 micron, now bear in mind, the study was done with the time domain OCT. So when you're using spectral domain OCT, you probably can add 40 to 50 micron to that. So the more than 450 micron, you can see in these particular circumstances, there is a big difference between those with anti-VEGF and laser alone. And clearly, when you got a thick retina, there will be something that to consider using anti-VEGF. However, that when you're actually looking at those with thinner retina, that around the 350 mark, then I think you can see the difference are actually quite small. And even in the middle group, the difference is not as big as one would like. And bear in mind, this is a controlled trial that using a large number of anti-VEGF therapy. So in real life, that quite often that we're using less number of injection than even in this group of 350 to 450 with the modern machine, then you will still think that that might not be as big of a difference as you will think otherwise. And similarly, that whether combination should be used, and you need to bear that in mind, this study is involving patients that who have already failed laser, and because that if they have not failed laser, they will not be able to join the study. So for those who already have prior laser, in other words, failed laser, then you can see that using ranibizumab alone seems to give you a better result comparing with combination. And indeed, that when you're looking at the in those who have never received laser in the beginning, that the combination group trails slightly better. Although this is actually not necessarily statistical significant, but give you an indicator that when a patient have never had laser treatment, a combination of the two modality might be the way to do, something to consider. So the third question is about what about those patients with good vision and central involved diabetic macular edema? And again, thanks to the DLCR network, that we have similar understanding of this group of patients. So when you look at protocol V, a patient with central involved DME with 20/25 or better vision. So patient with very good vision, and actually what happened to them? Well, you might recall that the study showed that even starting with anti-VEGF did not show a meaningful benefit after 2 years. However, that when we're actually looking at the observation group compared with the laser group have significantly later requiring the anti-VEGF therapy. So yes, you can observe the patient and then only treat the patient when needed with anti-VEGF and when they get visual loss. However, that if you do laser, then you can significantly reducing the time required for laser. In fact, the laser reduced the risk for aflibercept injection from 26% in laser group into the 36% observation group, and therefore the risk reduction toward 34%. So then the question is, what we have shown so far are all talking about conventional laser. And the question is that conventional laser potentially causes collateral damage, and that is whether we can do better with conventional standard laser. And indeed, that I was referring to using SubLiminal laser, or sometimes and also known as micropulse laser. The laser energy is delivering impulses, and there is less collateral retinal damage, and there is no visible scarring that you can see. And again, there is multiple talks on the concept of SubLiminal laser, but just to highlight the fact that this laser can show benefit potentially even better than the conventional laser that I showed earlier that is still relevant in 2021. And if you're looking at this case, that this is a patient that with a exudation in an area of edema outside the central subfield, and then you can actually see that the microaneurysm and in the fluorescein angiogram, and then you can see that there is leakage in the microaneurysm on the fluorescein on the angiogram, and then you can see the OCT with the retinal thickness. And then similarly that when you actually started treating the patient, this is only have one single treatment at baseline with the SubLiminal laser, and you can see even 4 months afterward the exudates are disappearing, and then microaneurysm seems to be reducing, and then by 12 months you can see further reduction of the exudation, and then indeed that it is not need to be retreated because they actually regressing very nicely. And you can see here that the retinal thickness improved. So in summary, for laser in DME, laser is still used in real life, even in the United States. Laser are similar to anti-VEGF in early DME with only mildly increased central retinal thickness. Combining laser and anti-VEGF in treatment-naive patients shows slightly better outcome. So don't be afraid to use laser when the patient already never have treatment before. But if it's true that after laser have failed, then you probably not much point or adding additional laser. In DME with very good vision, laser can delay the need of anti-VEGF therapy. So again, that if you are worrying about the patient need to pay for the anti-VEGF therapy or concerned about the risk of anti-VEGF therapy, laser can delay that further. So SubLiminal laser might also improve the outcome further. Since what I just showed you earlier are all talking about just conventional laser, but SubLiminal laser have shown that you can actually have able to have a similar surgical outcome in terms of efficacy, but more so that retinal sensitivity are actually improved after SubLiminal laser. So there is additional benefit for that to see that. In the remaining couple of minutes, I'm also going to show you a few other use of SubLiminal laser, in particularly that in central serous chororetinopathy. In CSR, I see in this case that you got a subfoveal edema and with a lesion quite close to the fovea, and then with a with the laser, with a subliminal laser, you can actually see the improvement of the subretinal fluid, and then improvement of visual acuity. And that's another case that which is had a much more chronic fibrinoid material, and even then the material can be absorbed relatively quickly, and eventually that even a few months later the fibrinoid material completely absorbed. And furthermore, that even in the case that when the CSC is very close to the fovea, the leakage point, and again with a subliminal laser, you could actually treat that. Obviously, that you want to have treated some cases before starting with some of these really cases that's very close to the fovea. And even with chronic central serous retinopathy, as in this case, that this patient had more than 2 years history of chronic central CSR, and you can see the angiogram showing diffuse leakage with RPE leak, and then in the ICG is also showing a plaque, and which is also contained. And I treated this patient with subliminal laser to the RPE leakage area, and then you can actually see that even with such a chronic case, and that can be treated and have the benefit very rapidly improvement of the central serous retinopathy. And I used the same protocol as in treating DME for central serous retinopathy. So in conclusion, that at least that laser is very useful in 2021, at least for diabetic macular edema and central serous retinopathy, in particularly that if you are using the subliminal laser. And thank you very much for your attention.
The next talk will be on subliminal laser therapy for macular diseases. And to follow on from what Dr. Victor Chong has discussed in his overview talk on the history and many modalities of subliminal laser therapy, I'll be focusing on diabetic macular edema and central serous choroidal retinopathy. These are my financial disclosures. I've been working on the Quantel laser systems for the last 11.5 years, starting with the SuperScan 532 and 577 nanometer lasers, and I recently upgraded 2 years ago to the EasyRed 577 nanometer laser system with the subliminal laser modality. So how does subliminal laser treatment work? Basically, it's very old technology that's been pioneered for more than 20 years. And what we need to know is that a proper subliminal laser is a train of laser pulses that are broken up in time. So we must understand a concept called duty cycle, which is the duration of on time and on and off time the laser has reached the retinal surface. And this is equivalent to a percentage. And what we're using in most cases is a 5% duty cycle, so a very low duty cycle to generate laser at the retinal pigment epithelium. The classical laser photocoagulation that you see is 100% duty cycle, whereby the laser is applied for the full duration of that you have set it for, and it creates heat at the retinal pigment epithelium and a dense laser scar. And this is what we want to avoid with subliminal laser technology. So by adjusting the on and off setting for subliminal laser, we managed to reduce heat diffusion around the surrounding tissue, and this prevents the formation of laser scars. The benefits are such that you can preserve retinal tissues while having effect on reducing macular edema at the macular area. The limitations is that many doctors complain that they cannot see these subliminal laser scars, and there's still some debate about what are the exact and best treatment settings we should use. In addition, I use the subliminal laser with the 577 nanometer wavelength, which I believe is the ideal wavelength to create a good laser reaction at the retinal pigment epithelium. without damaging the xanthophyll pigment, which is found predominantly in the macular region. Additionally, there's good penetration through opacities like cataracts, and you can allow you to titrate the power quite efficiently. We use a dense treatment or large spot size for the subliminal laser treatment, and the spot size is 160 micrometers, which are all connected together, which ensures a dense delivery of the laser scars, of the laser burns onto the retina without causing any scarring. Previous modalities or guidelines use small spot size with less laser burns, so there was a lot of gaps in between. This was done by small spot size and more laser burns with less gaps, and we then have moved on to a larger spot size with less laser spots, but maintaining the same density of the treated area. So these are the treatment guidelines that I will recommend: a spot size of 160 micrometers, 5% duty cycle, 0.2 seconds exposure time, using a Volt area centralis lens with a magnification factor of 0.94. This is all preset into the machine. So it's very important before you start treating is to titrate the power of the SubLiminal laser, because every patient is different. Some patients need a higher power, some patients need a lower power. So this is the only variable you need to make for SubLiminal laser. So once you determine the power level, whereby you choose an area outside the macular region, you use 5% duty cycle. I normally start at about 600 milliwatts. And if I see a mild reaction, I then reduce the power by half. And that is the treatment power that I need to treat the thickened areas around the macular region. So there is a power titration setting in the SubLiminal mode that you can follow. And it's very important that you do this. You don't exceed 1.2 watts of power. If there is no visible threshold happening at 1.2 watts, keep this as a reference level and use half of it for treatment. So 600 milliwatts, but I rarely have to reach this level. For the vast majority of patients, when you go titrate at 600 milliwatts, you see a mild reaction at 5% duty cycle, you reduce the power by half to 300 milliwatts, and this is what you need to do a good SubLiminal laser. So when you switch on the Easy Red system, you just have to pick the SubLiminal laser mode. And this comes up immediately under the titration power settings. And then you can start at 600. You can choose different levels of power and choose an area outside the macular region just to test it. And if you get a reaction, just click this button to reduce the power by half. Since the laser spots are not visible, you can use the multi-spot delivery system to ensure homogeneous application and dense treatment. However, I don't normally use this. I prefer to use single spot, as a lot of the time the areas of edema are not homogeneous, and you need to use your high magnification contact lens together with the guidance from the OCT printout, the OCT map, to see where the thickened areas you need to treat. So I don't normally use the multi-spot mode for this. So here's what you can do. If you see an area of thickening in this area outside the macular infratemporal, you could use a customizable macular grid or square and treat this area. But again, single spot laser, which are continuous and contiguous, would be adequate for this. So it's always important to avoid lasering the fovea. So again, to repeat, there is no visible reaction during SubLiminal laser treatment. There's no need to change the power for different degrees of edema. As long as you've titrated the laser before starting treatment, that is adequate. And use OCT guided for diabetic macular edema. For cases of central serous chororetinopathy, ICG and fluorescein angiogram guided treatment is required, because you need to know exactly where the area of leak is to treat it adequately. A lot of people ask whether you should treat the fovea. I generally avoid treating the fovea, but you can go quite close here, as in this case here. And it's not recommended really. So you can go quite close, but I would avoid the fovea completely if there's an area of edema around it. How long should you wait after subliminal laser treatment? I will wait at least 3 months for diabetic macular edema and about 6 weeks for central serous choroidal retinopathy. Here are some examples where you can use. For diabetic macular edema, you don't need a fluorescein angiogram. The best patients that respond would be the non-center involved diabetic macular edema. And what it does is induces biological changes at the retinal pigment epithelium that close the microaneurysms, upregulate matrix metalloproteinases, and dry the edema. What about fovea involving diabetic macular edema? The best treatment options remains debatable. I always start with anti-VEGF therapy as first line to dry the thickened retina and improve the vision. And if there is residual edema about 2 or 3 months after the initial doses of anti-VEGF, you may consider topping up with some subliminal laser, especially if the patient is unable to come back frequently and is needle phobic. If the edema continues to be treated, always continue with anti-VEGF therapy. As for CSCR, you need to do ICGA and fluorescein angiogram to treat the hot spots. And I would treat the hot spots in the mid-phase fluorescein angiogram, following exactly the same protocols as for diabetic macular edema. So here's an example from my colleague in Tarragona, Spain, a patient with non-center involving diabetic macular edema. And you can see here, the patient had subfoveal, extrafoveal subliminal laser treatment, and you just have to wait patiently. At 3 months, there's visible reduction of the edema, and at 6 months, complete reduction of edema with just one subliminal laser therapy treatment. Here's an example of fovea involving diabetic macular edema, and the patient had one anti-VEGF therapy at day 0, and at 1 month after anti-VEGF therapy, there is reduction of edema, but still some persistent edema juxtafoveal, and one session of subliminal laser therapy was applied here. And at 4 months, you can see complete reduction of the edema with improvement of vision. No further anti-VEGF therapy or laser was required. Here's an example of acute central serous choroidal retinopathy, whereby subliminal laser therapy was applied to the hotspots on fluorescein, which corresponded with ICGA. And you have to be patient, and there's improvement after 45 days, and at 3 months, there's complete resolution of the neurosensory retinal detachment. What about chronic CSER? So here's a male patient with persisting subretinal fluid for 5 months, and he had fluorescein angiogram ICGA showing a persistent leakage superior to the fovea. And with one session of subliminal laser treatment, it was completely dry after 2 months with improvement of vision. Here's a patient with almost 1 year history of chronic CSCR, and with treatment through the areas of hyperfluorescence on fluorescein and ICG angiography. There is reduction in the fluid, but vision did not improve very much because of the chronicity. But retreatment was done because of after 2 months, you can retreat. I will wait at least 2 months, and you have to repeat the angiography to see where the leakage. And after second treatment of subliminal laser treatment, it was completely dry. So that ends my presentation. I'd like to thank everyone for joining me today, and I hope this will help you in your journey towards using laser therapy for diabetic macular edema and central serous choroidal retinopathy. So that comes to the end of this interesting 1 hour on laser therapy for glaucoma and retina. Thank you for sharing. Thank you for taking the time out to join us today. And I'd like to thank our 3 speakers from around the world for sharing their extensive experience with us. And finally, I'd like to thank Quantel Medical for organizing this interesting symposium. And stay safe, and I hope to see you all again in a face-to-face meeting.